fighting you, you might not have a good pressure with pain. But the best time is already anesthesia, sleeping, and it will be the easiest help in your life. Okay, no, it's not fighting, nobody's fighting you, okay? And nobody needs to hold the child. So you have the LP and you can measure the pressure. So when you are following the children, you may have the head either small or large. Okay, this is one of the, so microcephaly, if the head circumference is more than 2 standard deviation below the mean, the best thing to plot it in your growth curve. If you see it very small, you have to take a family history. If the family, everybody head size is normal, not very small. You have to think about genetics. Trisomy 13, 18 will be obvious in the exam. The most common one we see all the time is the torch, cytomegalovirus. This is the most common cause of viral called microcephaly. Postnatal meningitis, it's for other rare causes. So ask about family history, do the titers for torch, consider karyotype and neuroimaging. What is more common I see all the time is macrocephaly, not microcephaly. Macrocephaly, if you do in the growth curve, you see the head circumference on the 98th percentile or more. So best thing I usually examine the child well, ask about developmental history, how the child is babbling, is able, like say for example, to sit alone, transfer objects from one hand to another at 6 months. So developmental milestones are perfect. Physical exam is normal, eye is normal, everything. Nothing, just his head is large. Look at the dad, look at the mom. If one of them head large, this is familial macrocephaly, reassurance. No head imaging is required. But if any abnormality in the milestones, you may need to go to head imaging. So we have 6 months old boys coming. This case is my patient, and this is the growth curve of the patient. But I remove the name. 6 months old boy is coming for his 6 months well visit. He's feeding well, able to sit with support. With support, he babbles, transfer objects from one hand to another. Physical examination of the head is elongated, and anterior posterior diameter is elongated and shortened in the biparietal diameter. Ridging of sagittal sutures is palpable. Upward crossing percentile. So his head, first time this child came is here at close to 5 percentile, 10 percentile, 50, then 98. Just the crossing. So the shape of the head plus crossing percentile up was really concerning. So what is the most likely diagnosis? Which one? Hydrocephalus? Okay. B, craniosynostosis. Yes, this case was a craniosynostosis, a scaphocephaly, which is elongated head, and the premature fusion of sagittal suture.
In this case, surgery is indicated now, or when?
At this age, I sent him to surgeon. By between 9 and 12 months, the surgery was done. Was scheduled at this age. Because the surgeon, as long as the intracranial pressure is normal, he's not vomiting or anything like that, but usually most of them, they will do it before age 12 months.
If in this case, head circumference going is normal, not the same.
Macrocephaly is one of the things, like one of the manifestations is more common with isolated premature fusion, like one suture, not combined. Combined usually syndromic, and the head might not be very large. But if you have the premature fusion of the sagittal or the corona, the head will be flat in the corona and may look larger a little bit in the growth curve. And also with the scaphocephaly, the most common one we see all the time is the head will be larger in the growth curve. But as long as you see the head abnormal shape and you can see the ridges and you suspect, you can send them to neurosurgeon. But it's crossing. He's crossing. He's crossing percentile. Like every time he's coming, he's going to higher percentile too quickly, and the head is abnormal. You know. But like say for example, most of the kids I have, because every child comes in the clinic, I will have to do all the measurement all the time, and will be blooded by the computer. So you will see all the children most of the time will be around 50. If it's 25, will be 25 all the time. If it's 98, will be 98 all the time. Like that. but it's overgrowing in the other direction. No. So if you look it up, isolated or benign form of craniosynostosis, they are more common to have macrocephaly, not microcephaly. Because this is also the concept. Most of us will say the head is not, because he has other sutures open already. He has the coronal is open, he has all the other lambdoid is open, but just only the sagittal one is prefused. So the head will be elongated, will look larger, will compensate. Okay? So it's more common for the common cases of craniosynostosis, the head will be larger or normal. Larger or normal. Okay? But the head shape will be abnormal. So this is the X-ray of this child. There is here thickening in the sagittal suture. So the diagnosis of craniosynostosis, abnormal shape of the head or abnormal head shape, palpable ridging of sutures, large head, isolated cases. Isolated cases may, some cases may be the head is smaller, but this is usually we see it with syndromic one. If you are in doubt, you can order a skull X-ray. Skull X-ray, you can do AP lateral or water view, or you can say craniosynostosis protocol. I usually personally leave the CT scan to the neurosurgeon. I don't order it because myself, I will not do anything with the CT scan. Okay, so the CT scan I will give it to the neuro. If you have honest, good neurosurgeon, just better to send it to them and then they decide. So the most common cause of abnormal head shape, this is what we will see all the time, is positional plagiocephaly. Craniosynostosis is like 2 in 100,000. So it's very rare. So not every abnormal head shape it will be. So if you look at this, this is a child, he likes to look to the left or to the right, do you think? He likes to look this direction or that direction? He likes to look this direction, okay? So the head is flat here and bulging here on the same side. So always look at the head. If you see flat on the side he likes to look, and bulging on the same side, this is positional. This is position. Okay? The ear, yeah, the ear, I couldn't get the ear here, but the ear in this case would be here forward and the ear would be backward. Okay? So this is positioning. Huh? Exactly, yeah. Yeah, this is positional plagiocephaly. I just look at their head. If you see the flat part, because the child like to look to this side, the flat will be flat here and bulging here. If you like to look this side, it will be flat here and bulging here. On the same side he's looking. So the treatment for that, number one, reassure the parent. The head shape will improve, okay? And you do repositioning. Like for example, if they have toys and the child likes to look to the left, make the toys on the right. If the mom likes to feed the baby, she can feed the baby on the opposite side. Put all the distractor and the light and the joking and the playing with the child on the opposite side. He prefers this way or she prefers this way, just do the other opposite side. Yeah, he did a surgery and he's doing good now. Yeah. Yes, he has to open it so his head can. I have 2 cases with
even without manifestation.
Even yeah, you don't wait for that. You don't wait. No. And the head will be horrible, you know, and will limit, the brain will not be able to expand it to the side. It will be just doing like. When you discover it, send to neurosurgeon. Yeah, when you discover it, send it to neurosurgeon. But honest one. Okay, so they don't do surgery for nothing. So rare causes you will know it from the beginning with the rare one. The rare, like septic metabolic disorder, storage disease like mucopolysaccharidosis. Genetic disorder is the one like Crozan or a Pierce or Pfeiffer. They look different. Their head يعني زي دماغهم كعبارة شكلها وحش جدا. So the diagnosis is clinical diagnosis usually and just sent to surgery. So let's do head trauma. So if you have 5-year-old fell on the stair from the 2nd floor and cried immediately. 10 minutes later became drowsy, unconscious. His pupils were dilated and unequal. He was rushed to the ER immediately. The CT scan showed biconvex. What is the most likely diagnosis? Subarachnoid hemorrhage, subdural hemorrhage, epidural hemorrhage, or subgaleal hemorrhage? Epidural. Perfect. So epidural hemorrhage is a case of emergency. Once they are admitted, you have to consult with a neurosurgeon and will give you the lens shape on the CT scan. And CT scan without contrast, okay? No contrast. The other one is subdural hemorrhage, will give you a different shape, will give you like looks like a crescent or the hilal, okay? And it's common with non-accidental trauma, non-accidental or child abuse. Both cases you need to consult with neurosurgeon immediately. This is now we'll go to the interesting stuff. So here is a 6-year-old boy presents you with complaints of progressive leg weakness over the past few months. Parents report that he often trips and has difficulty walking, especially after prolonged standing or physical activity. There is no history of trauma. Child's developmental milestones were normal. Physical examination noticeable for weakness in the lower legs, more pronounced in the distal muscles, increased deep tendon reflexes with lower extremities, mild sensory changes such as reduced sensation in the feet. There is a tuft of hair above the gluteal cleft. What is the most likely diagnosis? Transverse myelitis, Tethered syndrome, Guillain-Barré syndrome, or Duchenne muscular dystrophy. Tethered syndrome. Okay. Tethered syndrome is very important to be diagnosed early because any damage, whatever happened here, is irreversible. So the more we wait, the more damage and will not come back again. Okay. So it's important. Early diagnosis is the key.
lower motor?
Lower motor, yeah. It is lower motor because in the and
اللور موتور بيبقى فيها الريفلكس بتاع البروفلكسيا. اللور موتور بيبقى معاها البروفلكسيا. التيثر بتبقى
والله yeah, في الهايبر yeah, I think will be upper motor. Upper motor, that's right.
حالات التسع شهور early for neurosurgeon ولا سنتين ما طفل
ولا ايه؟
ولا يعني wait until يعني early if you are
No, we diagnose it early from birth.
Yes.
From birth.
Yes.
How? If you have the abnormal sacral dimple and the lower the sacral dimple and if it's open and associated with hair tuft or lipoma or hemangioma, the best thing to order MRI. You do not wait for tethered cord. You do that early. But it is minor and blind and it's high. So the higher the level, the worse. So the more close down to the anus is the lower the incidence with tethered cord. When it's higher and you see lipoma, hemangioma, you see tuft of hair and sacral dimple, big one, abnormal gluteal cleft. This case you order MRI. Ultrasound might miss it.
for surgery earlier ولا
دي ما اعرفهاش. انا كل اللي بعمله اول ما الاقي تيثر كورد when we were in NICU I remember we consult the neurosurgeon. But I don't remember if they have to do it right or they have to wait till the child puts some more weight or. But nobody will wait till they have symptoms because as they grow to stretch the filum terminalis. Okay. So tethered cord is distal part of the spinal cord is thickened and anchored in the spinal canal. And as the child grows, it will be stretched and become ischemic. So the red flags here, cutaneous in lower back, like tuft of hair, dimple, hemangioma, like lipoma in the gluteal cleft area. And the higher the lesion, the more likely association. Okay. And this will be associated with weakness, sensory loss in the lower limb, gait abnormalities, tiptoe walking, loss of bladder or bowel control.
الحالة دي congenital بتقعد 6 سنين. يعني هو congenital مولود بيها.
مولود بيها بس هو as he grow, it starts to show the manifestation and it's chronic. It's not acute, it's over time. So it may be associated with clubfoot, scoliosis, leg length discrepancy, The diagnosis is lumbosacral MRI. This is the best study. So, and the best study also for any sacral dimple or your MRI. Ultrasound may show, but it will not be definitive. In MRI, you will see that the conus medullaris is lower because it's pulled down, the conus medullaris, and the thickened or thickening and the stretching of the filum terminalis. Another case, 12-year-old boy with history of upper respiratory tract infection 2 weeks ago. He's complaining of back pain and abdominal pain, progressive weakness, numbness, and tingling in both legs. On examination, he has weakness, flaccid paralysis, areflexia on both knees. What is the best next step? Spine MRI or CT scan, spine X-ray, head MRI, CBC with CRP. What is the best study? You think it's one? Yeah. Why Guillain-Barré? Huh? Reflexia. Weakness. Yeah. It didn't say here progressive or progressive. Yeah, progressive weakness here. And numbness in the examination, flaccid paralysis. Yeah. So he has weakness. So this case is transverse myelitis. This is a case of transverse myelitis. It happens all of a sudden and usually triggered by viral infection. The most common virus is herpes. Huh? Yeah, it's supposed to say the venereal sensory level. Good job. So transverse myelitis is a post-inflammatory and because of inflammation of vertebral disc, limited to 2 or 1 or 3 vertebrae are inflamed, and the most commonly triggered by a virus like post-infectious herpes simplex, one of the most common one after vaccination, autoimmune spinal cord trauma. Huh?
Notification. Notification يعني for the personnel في ولا وزارة الصحة.
لازم تبلغ عنها. هي من ضمن الحاجات اللي بتتلخبط مع الجيامبري ومع التيثرد كورد، بس التيثرد كورد progressive over long period of time. This is all of a sudden rapid weakness and sensory level, as you said, and lack of bladder and bowel control.
الكرايتيريا بتاعت الجوامبري بتبقى له عقود. الكرايتيريا بتاعتها مربوطه. فاقصد الكلام اللي بيتقال هو الاكيد كويس الكلام ده كله بيدل عنه، لكن اظن كده مالهاش علاقه بالستريس. هتسيب كورتير كل المايليتس او فيكشوال سكوتس. كنترول. عشان اي اكيوت فلاسيد لكن مش فلاسيد بتيجي فلاسيد.
This one is with flaccid paralysis, areflexia.
في البدايه في بس مش
but the presentation usually areflexia. I didn't see it in any literature like it's give you hyper. They have muscle weakness and areflexia, and also later on they may initially areflexia, then later on will be spasticity and hyperreflexia.
Later on.
Huh? Later on, yeah. And the sensory level, as you
sensory
mentioned.
level.
Sensory level, yeah, like below 1 point. Upper is the sensation is normal, and lower the sensations are diminished. And bowel and the bladder dysfunction. How to make the diagnosis? By doing MRI in the back and lumbar puncture. The lumbar puncture, you will see elevation of white blood cells, like especially lymphocyte, and normal protein. And on Guillain-Barré, you will see elevated protein with normal white blood cell, which is cytoalbumin dissociation.
But after 7 days or 10 days, the cytoalbumin dissociation can become.
You mean in Guillain-Barré or here?
Yeah, for Guillain-Barré, cytoalbumin dissociation after 7 or 10 days. You can't discover further.
Yes.
For 2 points to differentiate the sensory loss level في transverse myelitis. وفي الجيلان-باري ascending
is ascending and there is no sensory level. They may have paresthesia, abnormal sensation, but still they feel and there is no sensory level.
Yes, no sensory level in Guillain-Barré but ascending paralysis. Abdominal spiratus.
Exactly. And the treatment corticosteroid. We have 11-year-old girl presents with 5 weeks of history of double vision and droopy eyelid. She feels tired and weak, especially at the end of the day. Her symptoms are always worse in the evening. Neurological examination is normal. What is the most likely cause of her symptoms? Myasthenia. Perfect. So myasthenia gravis because of antibodies against the acetylcholine, and they can be neonatal and congenital. Neonatal one because of maternal transfer of anti-cholinesterase receptor antibodies. Congenital usually familiar and no antibodies are involved. The classic one, the most common is juvenile and more common in female, and the onset usually 10 years and older. Generalized weakness, fatigability, ptosis, and ophthalmoplegia. The best diagnosis test is to order the anti-cholinesterase receptor antibody. This is the test of choice. And the ice pack, you can do that in the clinic. You have some ice cubes, you put it and you put it in the eye for 3 to 5 minutes. You will see improvement in the ptosis. EMG will help in the diagnosis. The treatment is prednisone, anti-acetylcholine drug like physostigmine, neostigmine, or pyridostigmine. Advanced treatment like thymectomy or IVIG. إدن؟
نحاول نستعرض
ممكن يحصل لهم حاجه ضريبه او اي ديسبيوزس ياخدوا الترجمين عنه. طبعا لازم الدكتور هو اللي شكرا.
معروف ان النورمال فلورا تحت الظروف اللي فيها النيوكم يحصل ممكن تتحول الى باكل
ما عدا الانترجين. هي عشان الانترجين هنا سبور فورمات. اولا هي سبور فورمات زي ما بقول لحضرتك، هي محوصله مش مايكرو اورجانيزم ماشي، هي سبور فورمات محوصله نفسها وريزيستنت لاي حاجه لاي هرش موديل. ما تحاولش، لا ده في يعني بقول لحضرتك مكتوب على البوكس من بره. خلي بالك الانترجين هنا دي جايه من ده هو مصنع واحد اللي بيعملها في ايطاليا، ما بنعرفش نعملها هنا ولا في فرنسا ولا في اي حته. هو مصنع واحد اللي بيعمله في ايطاليا وهو مش راضي يقول انه هو لحد. يعني مصنعنا في فرنسا ما بيعرفش يطلعها، هو ايطاليا بس اللي بتطلعها. هو النو هاو مش عايز يقول لحد، هو النو هاو مقتصر عليه بس. فهو السؤال ده سالناه ليه الوحيد ده في ترايلز هبعتها لحضرتك على الواتس. ما بيتحولش لاي باثوجينيك بكتيريا نهائي، زيرو.
انا عاوز الساينتفك بيز ان انا اخد
هي سبور فورمات. كل بص يا دكتور محمد، النورمال فلورا اللي موجوده في الماركت كلها يا اما ليف نورمال فلورا، يا اما ديد نورمال فلورا، يا اما بري بايوتيك اللي هو الغذاء بتاع النورمال فلورا، يا اما بوست بايوتيك اللي هو الحاجات اللي بتتبقى من النورمال فلورا. يعني مثلا النورمال فلورا البواقي منها ده البوست، اللي بتيجي منها الليف نورمال فلورا، وفي حاجه ثانيه زيه بس ليف نورمال فلورا سبور فورمات. سبور فورمات يعني هو السبور فورمات ده ما بيتحولش الى الفيجيتيف فورم بتاعه اللي هو بيحصل جيرمينيشن الا في السايت اوف اكشن اللي هو الانتستين، بس في اللارج انتستين ما بتتحولش اصلا، ما بتفتحش. البي اتش اللي معموله عليه الحوصله دي اللي هي السبور ده ما بيفتحش الا في البي اتش بتاعت اللارج انتستين بس. بقول لحضرتك مكتوبه على البوكس بتاع الكيموثيرابي دي، مكتوبه على البوكس بره، ما ينفعش، ما فيهاش هزار. دي ما فيهاش هزار ولا لا. بس انا يعني ايه، وبعد يعني لو حضرتك عايز تاكد من حاجه معانا، هو ما فيش حاجه في الحته دي كلها معموله سبور فورمات الا الانترجين بس. عشان كده بقول لحضرتك ممكن تتاخد مع ميه سخنه، مع ميه ساقعه، مع شاي، مع قهوه، هي بتتحط على اي حاجه، على اي اكل. يعني هي ملهاش اي كونديشن ممكن اخلي بالي منها خالص مع الانترجين جدا. ورايح حضرتك خالص، يمكن الدكتور اسامه عارف الانترجين هنا بره موجود في السوبر ماركت مش في الصيدليات بس. يعني هي اوفر ذا كاونتر. السوبر ماركت لايف ستايل ممكن اروح اخد الانترجين هنا واخد. يعني مش اللي هو لازم دكتور يكتبها لا ممكن اي بيشنت موجود في السوبر ماركت اي بيشنت ياخد انتيريو جيمين بس مش حاجه ثانيه عشان السيفتي بروفايل بتاعه. شكرا معلش عطلتكم. شكرا جزيلا. شكرا.
طب الجايزه بقى
يعني
بسم الله. This case is a 8-month-old girl was admitted to the hospital because of poor feeding, lethargy, and constipation. On examination, she is afebrile, no fever, drooling, had bilateral ptosis, new onset strabismus, and hypotonia in all extremities. Mother denied any exposure to honey or corn syrup. What is the most likely diagnosis? Infantile spasm. Infantile spasm, myasthenia gravis, spinal muscular atrophy, myelitis, or Duchenne. Yeah, the correct answer is infantile botulism. So, yeah, this is the point of the question. The point of the question that most of the cases you will not have a source in the history. So once you have the symptoms, regardless if there is exposure or not, أكلوا فسيخ or not, you don't have. As long as you have poor feeding, constipation, then weak cry, progressively start to be weak, hypotonia. This is botulism. Exactly, infant with it. So because why we mention that? Because a lot of kids the diagnosis dismissed because of lack. He didn't eat honey, so why botulism? Okay. So sometimes they are exposed to contamination, but not recognized by anyone. No one knows. Just so once you have the symptoms, you have to react. So don't wait for history that the history is positive for exposure to certain source. Okay. So this is the reason for this question. The exact source of offending spores is usually unclear in most cases. So that's why some they may delay the diagnosis because the history didn't say that the child is exposed to something.
Why corn syrup, please?
Yeah?
Corn syrup.
Corn syrup also any syrup. Sometimes they have some spores or contamination or canned food. Any canned food for adult. ممكن يبقى فيه spores. لأن corn syrup in the US they use it a lot for pancake. So
Canned food allowed for the children from
1 year. Once they are older than 1 year, the immune system is strong enough. But for adult and the children, it's better to stay away from canned food in general. But once they are 1 year older, the immune system is fully developed, so they can fight the botulism bacteria. So the weakness here is in a descending manner, the opposite of Duchenne. Okay. So the gradual onset of hypotonia. Sometimes the initial presentation only poor feeding and constipation. That's it. Poor feeding, constipation. So this is a red flag when you have a child who is healthy and all of a sudden constipated and doesn't want to feed. This is unusual. Okay? So you have to pay it, and then you have to examine the child. If the child's muscle tone is less, if it's not clear, you can ask the mom to come back or to observe if they start to be weak to go to the hospital right away. And so if you have poor suck, swallow, weak cry, sluggish pupil, so you have to examine it very well. So how to make the diagnosis? Isolation of toxins from the stool. You can do EMG if it's available, and the treatment botulism antitoxin IgG. Tiptoe walking is important for us to be aware that tiptoe walking, the most common is idiopathic, means that no underlying cause. A child just walking in tiptoes, like because they prefer to do that. This can be normal in the first 3 years of life. But also you have to keep in the back of your mind that can be associated with underlying other problems. The most important here is cerebral palsy, but mild form, not the full-blown cerebral palsy. Duchenne muscular dystrophy in the beginning, they may walk tiptoe. Okay? Tethered cord also, they may start to walk in the beginning tiptoe. Limb length discrepancy, if you have one. Also, the disease affect the hips, dysplasia of the hip, developmental dysplasia of the hip, DDH. Also, if it's unilateral, may do have tiptoe walking in one side. In the short side, they compensate the other side with tiptoe. Okay. So also, these are the causes of tiptoe walking, not the idiopathic. So management of tiptoe walking, if you do full examination, no hyperreflexia, because with the cerebral palsy you will have hyperreflexia, and if everything is normal, your exam is normal, no treatment until 3 years of age. Sometimes you may start from 2.5. Then you can do in the beginning physical therapy to stretch the Achilles tendon, okay, and for 6 months. Then if it doesn't work, then you have to refer to orthopedic for lengthening or for botulinum toxin injection to relax the Achilles tendon muscle.
So ساعات بيعملوا عملية للإطالة دي. بتوع العظام يعني. ساعات رايحين عظام يعني. ساعات بيعملوا عملية دي للإطالة بتاع اللي هي
lengthening, yes, or Achilles tendon. Sometimes they do serial casting.
دكتور كده مرة مثلا لما ياخد قرار إن هو يعمل عملية وأنصح العيان مثلا طب كمل أدوس عليه يعني مش ما محتاجش. عشان بقى هم فعلا مستعجلين في التاني جامد. أنا شفته مرة يعني رايحين عظام وناس يعني برضه يستعجلوا في القرار اللي هو الاسمي بتاعهم. أنا مش عارف وجيت أنا أحاول مثلا أعمل حاجة للعيان مش بعد كده كويس. هل مش كويس ده في مشاكل بعد كده يعني ولا هم كان قرارهم صح ولا هم فعلا بيستعجلوا؟
Most when I refer them to the orthopedic, most of them they observe until like there is no other option. They take too much time to do operation like that. Because of the complications, sometimes the result is not as they wish. So it's important to give more time for physical therapy. You can do non-invasive stuff like toxin, botulinum toxin injection, like Botox, but in the yeah. You can do sometimes they do casting, so like a casting, and then they remove it, and then the tendon is already straight. So, but the last resort is to do the lengthening. So, Duchenne muscular dystrophy is rare, but you may see it as X-linked. It affects only boys because of absence of dystrophy. Most of them are normal at birth, and then they start to show when they start to walk. They may have the waddling gait. Then they trips. They have falls, and then they have difficulty climbing stairs. They do have the Gower sign, hypertrophy of the calves. Generally unable to walk by 12 years. Death 75% by age of 20. The complication dilated cardiomyopathy, and sometimes sudden death. This is the classic Gower sign. So I had one case before. The reason for the visit was the child was not growing well. It's not related, but the child was not like really the weight. The mother was not happy with the weight. So order labs like general lab for failure to thrive. And one of the lab came that the AST and the ALT was significantly elevated, very high. So we saw that the child has some trouble with walking. So we added CK, the CK was 12,000. So it was a case of Duchenne, but the point here I want to reflect that the source of ALT and the AST was not the liver, was the muscle. So ALT and the AST primarily liver enzymes, right? But also muscles can produce the same and can be confusing. Both, more AST, ALT more related to the liver, but the muscle to some extent can produce small amount of ALT. So if you see liver in ALT and AST elevated, it's not necessary to be just the liver. It could be the muscle. Failure to thrive, but it's just a coincidence. And then when the exam, on the second visit, his walking, I asked her about the walk and development. She told me that his milestones is not normal. So I added CK because the muscle looks like he has muscle weakness. The CK was 12,000. It was a case of Duchenne. But what is really interesting in this case, initially the ELT and EST they were elevated and the source was not the liver. Liver was fine. Liver he was healthy.
Excuse me, but in that case, ALT is more significant, more than AST. ALT is more significant.
For liver?
Yes.
Yeah, for liver, ALT. Yeah, for ALT is primarily liver, but muscle can produce to some extent some ALT, but EST can be either one. Okay, you can have some high EST from the muscle or the liver.
But ALT in that case is more significant, more higher. Because AST significant for the heart more than for the muscle, as I remember.
Yes.
My background.
Yes, the liver is more ALT than AST. Yes. Hey, this case is interesting. This case is a real case from Dumyat. So as a 5-year-old boy is brought to your clinic by his parents with 4-day history of progressive weakness. Initially they noticed he had difficulty walking and was tripping over his feet. Over the past 2 days now he has trouble climbing stairs, getting up from seated position. He also had developed a mild difficulty swallowing. 2 weeks prior to the presentation he had upper respiratory tract infection, immunization up to date. On examination he has symmetrical muscle weakness, more pronounced in the lower limb, deep tendon reflexes are diminished with no sensory loss. Cranial nerves are intact, but there is some mild facial weakness. Lumbar puncture showed elevated protein with normal white cell count. MRI of the spine positive for nerve root enhancement. What? Yeah, exactly. This is a case of Duchenne muscular, I'm sorry, Guillain-Barré syndrome. So this child is, he almost went to 3 pediatricians before that. At the end he was referred to orthopedic, and they did X-ray on the extremities. At the end they went through many things, and then it was the diagnosis. But I think the most important thing why he was missed because of lack of taking a good history. So whoever just word from here, word from there, the clinician is busy. So he just whatever came to the mind, and from another pediatrician, then another pediatrician, then two orthopedics, and then at the end he was diagnosed with that. It's just the only thing, just to take the history in total like that, then you will have the answer as you did now. So Guillain-Barré, now with acute, the new name is acute inflammatory demyelinating polyneuropathy. This is a post-infectious polyneuropathy, as Dr. Muhammad says, is lower motor, ascending in character, in peripheral nerves, occurs in healthy individual, and you may not have in the history this child they had like a throat infection 2 weeks before this event. They may have the Miller-Fisher variant, which is ophthalmoplegia, ataxia, and areflexia. Common bacteria like Campylobacter jejuni, the one can give you bloody diarrhea, mycoplasma, viruses like EBV, cytomegalovirus, autoimmune condition, surgery, vaccination. Commonly we see it with after influenza vaccine. So the sensation, they may have paresthesia, and the weakness will be progressively, slowly, for an ascending manner, and begin distal in the legs, and then it will go up with diminished or absent reflexes. In rare cases, the reflexes may be okay, and this can be distracting. So if the reflexes are normal, doesn't rule out this disease. As long as the child is weak, progressively weak, and is having some autonomic instability, like facial flushing, tachycardia, bradycardia, fluctuation of the blood, and this child had all of that. Had the facial flushing, had tachycardia, blood pressure goes up, down, and then sometimes bladder dysfunction. And this disease will peak in severity within 2 weeks, and the recovery may take time. So even after giving IVIG, the recovery is not that fast. So this diagnosed based on the clinical appearance. You can do the CSF study, lumbar puncture. You can do MRI, and if you have a good radiologist, will see the enhancement of nerve roots. EMG also may help in the diagnosis. But once diagnosed clinical and the child is weak and nothing else to explain, you are not worried about transverse myelitis. Everything goes with Guillain-Barré. The treatment is next step IVIG. This will help to prevent the progression. Yeah, for transverse myelitis. Because not classically the standard of care to order MRI for Guillain-Barré. No. You diagnose clinically, you do lumbar puncture. Lumbar puncture shows the elevated protein. That's it. You start the IVIG. Corticosteroid one, but one is not the best. It's not the best. And if someone resistant to the IVIG is not doing a good job, some they combine it with corticosteroid. But the standard of care, two things: IVIG, plasmapheresis. These two. Corticosteroid may be added in special cases. But if it's not available, I think this is the only.
What's the routine before the discovering IVIG?
Huh?
Corticosteroid was elderly applied before the IVIG.
Yeah. But if I'm working and I don't have IVIG, the family cannot afford it, I will not leave the child, I will give corticosteroid. I will do that. The symptom will slowly over weeks, over a couple 2 to 3 weeks, you have to provide physical therapy because these children, they didn't walk for a while, up to 6 months to go back to normal baseline. You can give one dose. If the child is still like, you can give another one, same like Kawasaki. Huh? The dose is the same, 2 grams.
الريكفري في حاله جوالبري سندروم ممكن ياخد ويكس 2 مانثs. طيب انا الاي في اي جي يعني دلوقتي الحاله لسه ستيل مثلا فيها بعد على مدار مثلا 3 اسابيع، يعني هل ممكن ده ممكن بيحصل؟ ولو حصل هل ممكن اكرر الاي في اي جي اكتر من مرتين ثلاثه؟
Yeah. So if you give the IVIG and you see the child mild improvement and no worsening, you don't need to repeat the dose. You just wait. And then you provide therapy, physical therapy to strengthen the muscle again and to assure the family, to teach the family about the autonomic features like flushing, blood pressure. But these children, they have to have, if the disease is advanced and is affecting the respiratory muscle, they have to be in PICU. Because if it reaches the respiratory muscle, they may not be able to breathe in their own. But if you see mild improvement and no more progression, you know that the antibody is already blocked by the IVIG and no more progression. So you can just give them more time to recover. It's not going to be like 100% normal from after you give the medicine. It will take time. Yes, the spinal muscular atrophy is rare, is autosomal recessive. I will mention just the common one, Werning Hoffman, which is severe hypotonia and it presents after birth, frog leg position with difficulty feeding. This is the lower motor neuron, and you will see the tongue fasciculations, the flickering of muscles, the atrophy of the no sphincter loss, no sensory loss, no cognitive loss. So just the motor. And the gene mutation screening, you will confirm the diagnosis, and the treatment is supportive, and most recently now gene therapy. Okay, which one is lower motor neuron, which one is upper motor neuron?
One door.
So we have B, upper or lower? Lower. A? And the exam, I didn't get the picture of the eye because I didn't have permission from this patient. This is upper? Yeah, because the eye is normal, right? Yeah, exactly. So this is the classic Bell's palsy. This is this guy with the MRI had multiple sclerosis. So Bell's palsy, one of the things you will see in pediatrics, commonly triggered by viral infection. Okay, and you will see this is the weak part, this is the healthy side, and the treatment for that oral steroid is effective if it's given early within 3 days. We can give it for 5 days now. So we already talked about tics in the beginning, but tics, one of the things you will see, and they are intermittent, sudden, discrete, repetitive, non-rhythmic. Tics typically occurs multiple times a day. They are motor and some vocal. I have some cases are complex. A couple patients, they have this vocal one with swearing or making a big sound repetitively and not able to stop. This child was not able to attend the school. They have to. He cannot be in school because of the sound and the noise they make. So they are homeschooled because of that. So some cases are really severe and significant. And when it's complex like that, we call it, and they prolong more than a year, we call it Tourette syndrome. So the most common of tics, eye blinking. So a lot of parents, they bring the child and they think he may have something in the eyes. Then they are referred to ophthalmologist, and the ophthalmologist not pediatrics, and then they end up prescribed, and this happened with me here, prescribed eyeglasses, and the child doesn't have eye problem. It's just a tic and blinking. But when they are referred to ophthalmologist who's not pediatric, not familiar with kids, they may get prescribed eyeglasses because of the variation in age. If they are not familiar with pediatrics, so do you have one pediatrics you know that they understand pediatrics ophthalmology, or you send it to anyone here? في حد معين بتاع ophthalmology و pediatric ولا كله؟ هم يعني المدينة اللي أنا فيها مفيش فيها غير واحد بس أو اثنين يعني اللي هم they are rare.
مصر والاسكندريه برضه.
ها؟
لا مصر والاسكندريه دول ما فيهاش يعني في مصر والاسكندريه.
and maybe they are not too many يعني هتلاقيهم كم اسم كده بس. So the treatment of tics in general, reassurance, and if they are complex and significant, you may use alpha-2 agonists like clonidine or guanfacine. Okay, this is the treatment available for tics. I will not go through cerebral palsy too much. It's just I want to let you know that cerebral palsy is the most common cause is prematurity and low birth weight, not hypoxia. Prematurity and low birth weight. This is the most common cause of cerebral palsy. A patient with cerebral palsy, is non-progressive, and usually they have delayed developmental delay. For the slide I want to mention, or the points I want to convey here, is this one: red flags for early cerebral palsy. If someone rolling at younger age, younger than 3 months, this may be a red flag, but still some babies they do it and they don't have cerebral palsy. But one of the things to consider when someone rolling over from side to side and they are younger than 3 months, lack of head control, like head lag. No head lag usually by 4 months, right? By 4 months. So if you see head lag at 6 months, it is not normal. Persistent primitive reflex. If you have 6 months old and cannot open the fist, just contracting the hand like that, this can be early sign of cerebral palsy, lack of fisting, because by 4 months they are able to open the hand and let go. Okay. Not sitting by 9 months, not pulling to stand by 12 months, persistent tiptoe walking. When you have someone with persistent tiptoe walking, one of the differential is mild form of cerebral palsy.
resistant يعني يقدر ان هو resistant.
Like 3 years. 3 years and older, he is not improving, is not, or some kids they do tiptoe walking but occasional, but most of the time they are walking normal, that's okay. But the one all the time just like walking like that, most of the time in tiptoe, this is not normal. And then when you examine them, you do the foot like that, okay? So normally you are able to dorsiflex the foot like this, all backward. This is normal. For kids with where it would be just like this. The Achilles tendon is so tight, so you cannot dorsiflex this because of tight. And if they continue walking like that, they will have future problem to play, to do certain sports, because they just the way they run and walk, they cannot walk normal. So general manifestation of cerebral palsy, delayed milestones, abnormal muscle tone, and the hyperreflexia. This is the most important. Hand preference before age of 1 also is a red flag. Hand like for right and left, you know, hand preference. Usually before 1 it should not be no hand preference before 1 year of age. The red flag for possible hemiplegia. Growth disturbance, constipation is very common with kids with cerebral palsy, seizures, intellectual disability. So the treatment is the diagnosis based on the physical exam and review the pregnancy, prematurity, how much, what was the full term or preterm, how was the delivery, neuroimaging in some cases, and they prefer to be MRI. And you have to send to ophthalmology for all kids with developmental delay. In general, you have to have eye exam and ear exam, hearing test and visual test. This is very helpful. And the speech language evaluation, metabolic genetic, if it's indicated. If it's having seizure, you can do EEG. And the management is a multidisciplinary approach. You have to have like physical therapy, speech therapy. You have to have a referral assistant with orthopedic because of the contracture of limbs. GI for reflux and the constipation. So it's a multidisciplinary approach. Okay. So that's it. This is the end. So thank you. So now just to conclude, if we have someone with seizure, persistent seizure, what's the first step? What's the first thing to do? Oxygen. Okay. If you have someone with weakness and not able to walk very well, all of a sudden, and hyperreflexia of the knee, and you saw a hemangioma in the back. Hemangioma in the back. Tethered cord. Okay, have someone with seizure or ash leaf spots. Yeah, seizure with ash leaf, tuberous sclerosis. Okay, if you have someone with a history of upper respiratory tract infections, back pain, okay, sensory level. Okay, weakness in the lower limbs. Next step to do? Yeah, MRI for transverse myelitis on the back. Okay, if you have someone with upper respiratory tract infection, progressive weakness of the muscles in ascending manner, okay, and some autonomic features is Guillain-Barré. Okay, perfect. And if you have someone with migraine headache for persistent and for recurrent, and you want to prevent the headache, what's the ciprofloxacin or topiramate? Okay, that's it. Thank you. Any questions?
حالات الجيلان-باريه يعني في اطفال بتاخدوا الجيلان-باريه بياخدوا الفايت بي اي جي بعدها بيخاف الاهل من اي انفكشن الفيروس بالذات. ايه اللي ممكن تقدر تعمله؟ هل فعلا تبقى
ما تقدرش تعملي حاجه
خالص ولا حاجه تزيد الاميونيتي؟
لا على فكره حته انك تدي حاجه للاميونيتي دي از ا ميث pharmaceutical بس يعني انما is not true to give something to boost the immune system or to activate the liver enzyme. الحاجات دي اللي بدي it doesn't exist in the US. No medicine for immune system to. The only thing someone deficient in has immune deficiency and maybe granulocyte colony stimulating factor or something like that. But the vitamin and the certain things to make the immune system better, the parents always ask, do you have anything to boost the immune system? This is a myth. It's not true. There is nothing in medicine to boost the immune system.
If deficient بس معوض. If deficient to compensate.
If deficient in something, you compensate. Okay? And the normal, regular diet, well-balanced diet, this is what will boost the immune system.
دكتور بعد اذنك لو في تشايلد بيبقى بوست موتور سكيلز يعني في ديفلوبمنتال كويس وبعد كده بيحصل له withdrawal يعني على 6 شهور او 7 شهور.
ولد ولا بنت؟
ولد.
ولد. بيحصل له regression؟ Well, you do developmental evaluation and you do neurological exam. Everything is normal and just developmental is not progressing. It could be one of the things, autism, for example. Vitamin D. Vitamin D is overdiagnosed a little bit because now is because of the. You may see vitamin D in other countries now, but we are now most of the people they have access to food and milk and all of that. So it's very hard to see cases of classic vitamin D deficiency as in the books. Like you will see the fray of the femur or the bone, and high alkaline phosphatase and low, all these classic things. So, but if you suspect vitamin D, you do the alkaline phosphatase, you do calcium level, and if you see at the X-ray for example on the elbow, if they are normal and the vitamin D is normal, and now you can test vitamin D directly, right? Vitamin D level. If it's normal, it's not vitamin D. Autism, developmental delay, developmental delay with no regression. But if you have a girl with regression and her head is not growing with microcephaly, you have to think about Rett syndrome. Rett syndrome in girls is a developmental regression with autism, mannerism, and they have the head is not growing. You will see the head is declining. It's not shrinking, but it's not growing. So you will see in the growth curve, the head circumference is going down. And developmentally, after she was speaking a little bit, no more speech, and she started to have a neurological deterioration. This is called Rett syndrome. But Rett syndrome in boys is incompatible with life.
Yes. For the CB cerebral, by definition, it is a motor instance. But actually, in our clinical practice since a long time, it is there is comorbidity with mental retardation, and the explanation at that time that the hypoxia that insulted the brain to also affected the performance.
Yes, definitely.
What is your experience with
The
that?
same. Most of the kids with cerebral palsy, few of them, I have few, they are in college. They go to educate, they are good. Their brain is intact. But some kids, their brain is affected. Yeah, like hypoxic ischemic encephalopathy, for example, was the insult. So the brain was damaged. But one damaged one time and they say no more progression. It's not like polysaccharidosis. It's not like metabolic and
Not progressive.
Not progressive,
Non-progressive. This is the definition.
Yeah.
But always I observe that accompanied by comorbid mental retardation.
Because the brain was
with
very
degrees.
Yeah, because the brain was hit hardly in the beginning, and that's
association يعني as association not a part of the disease.
association. Yes.
Association.
شكرا جزيلا لضيفنا العزيز الاستاذ الفاضل الدكتور اسامه نجا، وان شاء الله موعدنا يوم الاثنين القادم ان شاء الله مع الديرماتولوجي يعني مبدئيا في نفس القاعه ديرماتولوجي.
السكرين دي جميله ما شاء الله.
غيرنا البروجيكتور وغيرنا والمايك اتصلح على فكره.
لا ما شاء الله.
تاني كده.
تمام.
تاخد نفس طويل.